Good morning. Today I am very happy to present a very unique technique of splitting a mandible in a very easy and predictable manner. Traditionally, due to high density of the cortical bone in the mandible, we used to think that we needed to do a two-stage approach, which means we make a corticotomy in the cortex and make a green stick fracture and come back 3 to 4 weeks later and actually do the ridge splitting 3 to 4 weeks later after inducing a green stick fracture. However, with the aid of newly designed implant, I would like to present a case where we split the mandible in just one surgery using this unique implant, thereby decreasing number of surgery for the patients and increasing the predictability of a rigid splitting technique in part 2 of my presentation. Before I go into actual technique itself, I would like to discuss a little bit about other techniques available uh, and compare and contrast which techniques I use in which situations. For example, when I have a maxillary ridge splitting versus mandibular ridge splitting, as you can see in this slide, I would like to always split the ridge on the mandible versus maxilla. Maxillary cortex is very thin and is more prone to fracture when we are trying to split the ridge. Therefore, it's more technically challenging when you compare with the mandible because of high risk of fracturing the buccal plate. Also, in maxillary anterior and bicuspid area, we always have this concavity at the apical portion of the bone, and therefore, when we split the ridge, our angulation of implant is always too buccally displaced, and I don't like the outcome of angulation of implant in maxilla. Therefore, I do not like to do ridge splitting on maxilla. Now, in contrast, on the mandibular ridge is always more lingually inclined, about 20 degrees. Therefore, when you split the ridge, my implant always becomes on the central fossa. And also, because it is lingually inclined, when the buccal plate is buccally displaced, we will gain about 1 to 2 millimeter of height as well by doing ridge splitting. So I always prefer doing mandibular ridge splitting compared to maxilla. And the second reason is that because of high density of the cortical bone, when we split the ridge, it's less likely that the buccal bone will fracture off from the host bone, and because of high density, we can still maintain good initial stability of our implant even after splitting the ridge. Now, when we have a multiple site versus a single site, I always prefer multiple sites because by having a multiple sites, you don't have to make a very long vertical cut. In contrast, when you have a single site, it is very challenging because you need to make a very long vertical cut in the bone, or else there is a high risk of fracturing just the cortical portion, just the coronal portion of the bone. Therefore, I recommend making very long vertical cut for the single site, and for the multiple site, very long site mesiodistally. You don't have to make as long vertical cut, and it's much easier to do multiple sites because you can use multiple implants to split the ridge. I will have a video of this technique at the part 2 of the presentation, um, so please bear with me here. Now, when we compare GBR versus ridge splitting, I always like to do ridge splitting whenever possible because of these reasons. When we do GBR, it takes much longer for the bone to mature. In contrast, with the ridge splitting, when I go back 3 to 4 months, I have a solid bone, very high density bone when I compare with the bone created by GBR technique. And also the cost of material in GBR technique is much higher compared to rigid splitting technique, because in GBR I like to use titanium reinforced non-resorbable membrane. Now, number of surgeries, typically rigid splitting, I can do everything in one surgery, but when we compare the GBR, I always like to do in two-stage approach to increase the predictability of the outcome, which means I place the implant at the later stage. I must say that getting a proper implant position and angulation in both techniques is very challenging, because in GBR, when you try to place implant in newly formed bone, always the newly formed bone is less dense than the host bone. Therefore, you have a tendency to drift away from your host bone. Therefore, making osteotomy in bone created by GBR is very challenging. In contrast, in ridge splitting, because we are splitting the ridge, getting the proper angulation of the implant is somewhat challenging. So there is a surgical learning curve in both techniques. Now, the stability of the cortical bone is excellent in ridge splitting technique compared to GBR bone, because the cortical bone created from the ridge splitting is the natural bone, and both techniques is very favorable if the base of the ridge is pretty wide, thereby increasing the blood flow to our surgical site. Now, minimum dimension required for ridge splitting is much more favorable in GBR. Therefore, if I have very narrow ridge, I will choose GBR technique. If I'm working in maxilla, I would choose GBR technique. In contrast, in ridge splitting, you can do with 3 mm of ridge, but if you split a 3 mm ridge, you will have a very thin buccal plate and you will have a resorption and you will not have a good outcome. Therefore, for ridge splitting technique, I recommend minimum of 5 to 6 mm of residual ridge, because in this way we can maintain minimum of 2 to 3 mm of buccal plate even after splitting the ridge. So as I mentioned again, you can split the ridge with just 3 mm, but if you want to have a good predictable outcome, I recommend 5 to 6 mm of the ridge. If not, please do a GBR technique, because you really want to have enough bone, especially on the buccal bone, to have a good predictable outcome. Now, there are very common complications in GBR. Getting primary closure in both GBR and ridge splitting technique is very critical, but I must say ridge splitting is more forgiving in terms of getting primary closure. So for the beginners, ridge splitting technique is much easier, but there is a risk of fracturing a buccal plate. So you need to have a plan B in case buccal plate fractures. So let me first discuss a GBR technique, and in part 2 I will show you my unique ridge splitting technique in the mandible. So when this patient came in to get an implant consultation, she was going through many restorative therapy at this time, and the dentist referred me to do implant on number 2 to number 5 area. As we can see in the CT scan, we have a very narrow knife edge bone with lack of keratinized tissue, and in the sinus we have pneumatization as well. So I decided to do a sinus lift and GBR at the same time and place implant at later stage. I like to do this technique in two-stage approach, which means I place implant at later stage because when I'm doing GBR, I want to maximize the blood flow to my graft area. Now, I used a lateral window in this case because this is a class 4 defect according to my classification, which means is severely pneumatized and very narrow ridge buccolingually. And I use my lateral window technique, which is very simple and easy to use, because all we need to do is we need to use just a simple trephine to make a punch in the bone, making a groove in the bone, and then utilizing a unique beer bottle opener concept to pry open the lateral window, as you can see in this video. So it is very easy technique in that we use the trephine just to make a groove in the bone, and then we utilize this unique instrument to pry open the lateral window off from the sinus wall. So very easy and unique technique can be utilized to do this. And if anyone is interested in learning this technique, please check out my website www.ce4dentist.com. We have some live surgical training where we offer our attendees to actually do this procedure in live patients. Now, after elevating the sinus membrane, and we need to verify whether the perforation has occurred or not, and I do this by having the patients breathe in and out and by verifying the membrane going up and down, as you can see in this video. So after I verify that, I will pack bone graft into the sinus, and I will now attempt to do GBR. So here we have a very knife edge bone, and it's only about 1.5 millimeter in buccolingual dimension. So after doing a sinus grafting, I over augmented with FDBA and GEM21, and I used titanium reinforced Gore-Tex membrane in the bicuspid area because I needed to make a very predictable buccolingual augmentation. In contrast, on the posterior, it wasn't as critical because the base of the bone was pretty wide, so I used just the collagen membrane. Later on, when I uncover, you will see a huge difference in augmentation using titanium reinforced membrane versus just the collagen membrane. So utilizing internal matrix sutures to push down the membrane so the membrane does not move during the healing period is very critical. And I have not used any tags in any of my surgeries, and I can predictably stabilize this membrane with just using internal matrix sutures. After utilizing internal matrix sutures to stabilize my membrane, then I will make a primary closure using a resorbable suture. So the internal matrix sutures, which is very important, is used with non-resorbable suture, in this case Gore-Tex sutures, and the outer layer, which is not very important, is just very passive suturing, is done with resorbable suture like 5-0 chromic cut. After 8 months of a surgery, we have a very nice healing. As long as we don't get exposure of the membrane, we will have a very predictable outcome. So as we can see here, when I uncover, we have intact membrane without any infection, and when I remove this membrane, I can appreciate amount of bone volume that I have gained through this surgical technique. It's very predictable. It works every time as long as my tissue does not dehisce. As long as I get a primary closure during the healing period, this technique is always predictable, and I can always predict how much bone I will get. So knowing how to manipulate tissue and getting primary closure is very important. And in my hands, I can do this technique in 99% of time with good predictability, with a good surgical technique. Now this is a before and after, and you can appreciate how much we gain. Here we gain about 12 times much thicker than what we began with. So now anybody can place implant eh, after doing GBR. So GBR really changed the scope of our implant dentistry, and I no longer have to place implant where the bone is. I can create the bone anywhere I want, utilizing sinus lift and lateral ridge augmentation. So this is a before and after picture to show you how much bone we can gain with this GBR technique. But one of the disadvantages in maxilla is that the bone quality of this newly formed bone is very poor. Therefore, as I mentioned earlier, making osteotomy is very challenging because you will have a tendency to drift away from the host bone into newly formed bone. Therefore, the implant always becomes more buccally displaced. So in this scenario, I always use piezo to make osteotomy. Why? Because by using piezo, I no longer drift away from different density of the bone. So I utilize piezo with ample irrigation to indicate where to start the osteotomy, and I will finish the osteotomy with the piezo, and I will install the implants. Uh, when you're doing multiple adjacent implants, I always recommend splinting the crown, and that's also a very long discussion that we can have. But I always like to splint my implant crowns, and whenever I try to splint them, I like to put them in slight tripod position within the bony housing to lessen the force. And I got this from Dr. Carl Mitchell's book in terms of why we need to splint the multiple implants to reduce the cantilever force buccolingually. So as you can see, GBR technique is very predictable, and it could be it could be done with a very simple technique, not needing to use any bone tacks and just using sutures to stabilize the bone graft material. So in contrast, I would like to share with you a one-stage mandibular ridge splitting technique. Once again, this is not a two-stage approach where we make a cut and then come back 3 to 4 weeks later. This is just a one-stage approach, and we don't use any bone condensing drills. In fact, we only utilize dental implants to split the ridge. I learned this technique from my mentor, Dr. Park from Korea, so I would like to thank him for inventing this technique. And he utilizes this specially designed dental implant called AnyRidge, and it's manufactured by Megagen, and it is a very easy way to split a mandible in very predictable manner. So with this uniquely designed implant, because of its aggressively threads, it allows the implant to grab the bone at the same time, displace the bone buccally. And long-term result of this implant is very good because it tends to maintain the crest bone very nicely. And the reason is the crestal portion of this implant is much narrower than the body of the implant. Therefore, it increases the blood supply to the crestal portion of this narrow ridge. So I recommend using this type of implant if you want to preserve amount of bone in the crest, therefore reducing chances of recession.